Great. So the first question that came through relating to the scorecard, in addition to being browser agnostic, how important did you find it to be device agnostic, for example, tablet or smartphone versus a PC, or app-based versus browser-based?
Hi, this is Elizabeth. So I'll address that. I would say that the literature was showing being device agnostic as well. One of the challenges was trying to find literature that was, most recently published, where I think that would pick up on. So it didn't quite make the scorecard, but that is absolutely of significance.
And that question was from John Keyes. And then a question from Madison Beatty. Were these scorecards developed with the input of patients or only providers?
This is Elizabeth again. So that was one limitation of the final research product, is that we didn't do interviews with patients. So the input from patients would have been from the studies that were conducted that were used in the literature review articles, as well as the input from the healthcare leaders across the country that we did during the qualitative phone interviews. So not direct interviews with patients, but definitely from within the source of what was included.
And another scorecard related question, did you get any input about timeliness of patient data in the portal? For example, sometimes data is released to the portal immediately as it becomes available, whereas other times patient data is not released to the portal for a day or two.
Right. So most of the studies that I looked at did not go into the exact hold time of data. However, we have big experiences with that at Emory. So I just want to look to either Shannon or Dr. Hollberg to talk about the release time.
So I personally think the sooner you get the data into the patient's hands, the better. However, there is another viewpoint from some of my colleagues that it is better for patients to receive data and results in the context of a conversation or a message rather than directly on the portal. And so I think, that one area where we struggle in is particularly with oncology patients, and, whether it's what is the best care if they're going to have a negative finding for it to come via the portal, or for it immediately released versus time for the physician or APP to give that patient a call and discuss the result. So it's something that we continue to struggle with. We initially started with a week, and then as my colleagues with results released for radiology and lab, and as my colleagues realized that there wasn't harm, then we continued to slowly push that back. And then, and that's how we ended up at 36 hours for labs and 72 hours for radiology, trying to strike a balance between those providers who want to be able to have time to call patients versus not making the receipt of results entirely based on the clinical care team's convenience and when they get to it.
And another question for Emory, what process did you use to get patients involved in design and testing? Was it random outreach or marketing for volunteers?
So we have a robust group of patient and family advisors, and we look to that specific group of patients. So it's those patients that are involved in our formal program.
This is John. Can I just make an editorial comment? We hear so much skepticism about whether patients can contribute to this process, and it's great to hear that response from Emory. Recall Rosie's comments. Patients can be incredible participants and governors, in this process. And please, it's really frustrating for us to see in some places how little involvement patients have. Sorry. Go ahead, Jeff.
Another question for Emory. How many people and who, in terms of who was involved, rated the portal scorecard?
And so clarifying question on that, is that how many people were part of the project to use it to score the portal?
Yes, it was a small group of us. So it was Shannon Caul and Elizabeth mainly. because it really was a matter of yes or no on do we have features or not.
And another question for Emory was, who does the portal team roll up to? Which department does it live in?
So the portal team lives in clinical informatics, which is my department, and rolls up to me as the CMIO.
And I will say that I saw across my qualitative interviews, it was often, the portal is often kind of, I won't say dumped, but like handed on the CMIO at organizations kind of as like another duty as assigned. And it's a testament to Emory that they've been able to build the case to actually have a team to make work possible.
Yeah, I have a really close partnership with the chief nursing informatics officer, and there's a variety of things where we take turns who has the lead. So even though it rolls up to me, there's also a tight partnership with our nursing colleagues.
Another Emory question. Oh, sorry, somebody else.
Yeah, I just want to remind folks that if you do want to verbally ask a question, just raise your hand. And then I did want to shout out, we got a number of comments in the questions area that aren't questions, but a ton of praise and thanks to Rosie for your presentation. Folks saying excellent presentation, people who say they're pounding on their desks in support of Rosie, one of the best patient voices I've ever heard, powerful arguments and well expressed. So just want to share the love there. Back to you, Deb.
Another question for Emory. How did you add information about why tests were ordered? Did you attach diagnosis codes?
We don't have a ton of information about why those were ordered. As part of radiology results, they will have the reason for exam as part of that report. So that's just a standard field as part of the report, but we haven't done custom work related to that.
And I think you might be also asking then too about the education that Shannon's working to add with links to health content about like, what is this test and why is it typically ordered? Likely not directly linked to that patient's diagnosis code.
Correct.
And then here's a question for everyone. So maybe Rosie can give her perspective first and then the Emory folks. Our providers and care teams are being overwhelmed by messages from patients. How has Emory managed this? What is the patient perspective? How should we manage patients who submit 1,000-word questions? Rosie, do you want to respond first?
Well, I guess for me, when I send a message, it is the clinic has, or the doctors have a nurse that looks at it. They also know their patients. They know patients who ask the reasonable questions and then kind of waylay those questions that are not emergency questions and push those off later. I think that, managing the questions should not be stopping the questions from being asked. You might use a scribe to help manage those questions. You might use, an intern to help manage those questions. But I think the questions have to be able to be asked, because if you don't give the chance to ask the questions, you've cut the patient out of that side of communication.
This is Dr. Hollberg. I'll chime in a little bit from the provider perspective, and then Shannon can talk about the portal. So I absolutely agree with Rosie that the idea is not to shut down those questions, but it is about making sure that you address and answer the patient's questions in the right environment. And so we encourage our patients that the use of the portal is for, shorter questions, not for urgent things like, chest pain or shortness of breath or severe depression. And so we have limited the words now at the request of our providers down to 500 words. And our providers will sometimes respond and say, that we need to have an office visit so we can have a face-to-face conversation about these questions.
And from a technical perspective too, we have the portal messages routed to different clinical routing tools, so they can be triaged to then be forwarded to the appropriate person. So there's not messages going to the incorrect folks to answer. We also, for some messages that provide some standard messages that providers will send to patients, we've disabled the ability to have reply all. So patients will have to start a new message that will then get routed appropriately based on their questions. So it's not just an influx of reply all emails that go back to the provider.
I would say, and just as one final comment, I would say we have some providers that complain, but not a lot of providers. It's a minimal amount of complaints that we get in terms of being overwhelmed by the messages. And I think that, really goes to show that it can be a very effective tool, particularly for having, asynchronous conversations. So you don't, instead of trying to get hold of the doctor, or trying to get a hold of the patient and having 3 or 4 wasting your time doing 3 or 4 phone calls back and forth, patients can ask their questions and then, get responses from the provider. And we really use that multidisciplinary approach where we have nurses and providers manage the messages as one of the ways, or one of the strategies to decrease the burden.
This is Rosie.
This is John. Just a comment. From a notes perspective, we hear overwhelmingly that this doesn't happen, and that when it does, it is predictable which patients are going to ask a lot of questions and ask long questions. That said, it would be incredible to have some data. And to the Emory folks, as I look at what you all did, which is incredible, and you were adding improvements, it would be wonderful to get some sense of which, if any, of these improvements did result in a barrage of patient questions, and which didn't. One of the great things at Emory is you're data-driven. Boy, is it unusual for us to see informatics folks be data-driven and know, when we did this, well, what happened? Okay? Just a comment. Rosie, were you going to make a comment?
Yes, my comment was, I'm thinking of all the questions that I might have asked over the last 10 years through my portal, and I can tell you that I don't believe any of them were more than 50 words, because a good question, a question that's important to a patient, shouldn't be 500 words even. It should be less than 100 words, because you can ask that question very concisely, and then it'll get to the right person, and then it'll be easy to answer. And I think, if you have a patient that's abusing it and asking, using it just to ask every silly question, or every question that you just to get attention, that's a different ball game. And then you address that patient's concerns. I think you have to know your patients, and that's the key. Know what matters to your patient, know your patient, and why they're asking the questions.
Go ahead, Deb.
Another question about Emory's portal. How many languages is it available in? For languages the portal may not be able to fully be translated in, what are you doing to make the portal effective for patients who do not speak English?
So currently, we only have it in English. It can be available in Spanish. And then through the use of our Patient Portal Contact Center, we use translation services to answer patient questions that are incoming.
Rosie, a question for you. They said, thank you for sharing your experience. What do you think about expanding the portal so family members can also communicate on the portal?
I think that the best way to do that is if the patient gives a proxy to a family member, and then that family member can ask questions because they have a proxy to the portal. I let my husband ask questions through my portal because, basically he was looking at the wound. I couldn't see the wound. So then he would ask the question, but I just let him ask the question because he was my partner, my caregiver. But I think proxies through portals might be the answer of letting people ask questions or not ask questions.
Has Emory explored disparities in portal enrollment and use by race, ethnicity, language, sex, etc.? Nationally, there have been disparities identified in portal use.
And I'll chime in before I hand it over to Shannon. This is Elizabeth. So in the research that was conducted in the development of the scorecard, what was really interesting is it showed that across, different ethnicities and races and socioeconomic status, there was not a difference in whether people wanted to use a portal or not. However, where the issues then come up is kind of the crux of this question is on the healthcare side, actually making assumptions on behalf of the interest of those patients and not offering access is what some of the literature has shown as being kind of the downfall there. Shannon or Dr.
We haven't done socioeconomic or racially targeted projects. What we've done instead is take the approach that Elizabeth was alluding to, that, you know, our assumption is all patients are interested, and so we make sure that all of our sites are educated about how to enroll and are educated about the support services that are available through our contact center.
And this is John. I just want to mention Mount Sinai in New York. We've got a grant from the New York State Health Foundation, and with that money, hired a Spanish navigator. And we just looked at their results. The Spanish navigator enrolled hundreds of Spanish-speaking patients into the portal. So that's certainly a suggestion that, you know, if you build it, they will come.
Yep, I totally agree.
A quick question for Emory. What delay do you have on pathology results being released?
It's on our FY20 plan to add pathology results to the portal, and we will probably start at somewhere between 3 and 7 days, depending upon the provider's comfort level. We've done everything that we started with at 7 days and then decreased the time, just to kind of ease the results and to manage some of the concerns or the expectations.
And then with multiple portals frequently comes patient confusion. How have you managed these issues so that patients know which portal to use for which purpose?
So we try to communicate that as effectively as we can through our patient education materials, and we know it's confusing and it's a struggle, and that's why we have the centralized patient contact center. When the calls went through our large central contact center, we had a wide range of knowledge and thus a wide range of experiences for our patients when they asked their questions, because, you know, when you're talking about hundreds of call center agents, it's hard to have them all educated on the nuances of the portal. So by moving to a call center that's focused solely on the portal, we've been able to increase the availability of resources and the quality of the resources that we have for patients to get help. But we know it's confusing, and we wish it wasn't like this.
This is John. The time, I think, is approaching the end of the hour. There is a question further down I want to make sure we answer. The question is, did you have orientation training for patients to be involved like Rosie? Any suggestion to help get Rosie clones? First of all, on the Open Notes website, there's a toolkit for patient and family advisor councils, which is the major way at Open Notes we've tried to find and orient and educate patients in this process. And again, when an organization makes a commitment to do that and do it well, it works well. There are several that have done that. UCLA, for example, has had a PFAC devoted to IT issues for 2 or 3 years. There's 2 three national groups that have been following IT issues and what's going on here. We've worked a lot with PSCC partners, and they helped organize the PFAC that Rosie is on, and they definitely know how to work through these issues. The Institute for Patient and Family Centered Care, IPSCC, Bev Johnson's organization is also very interested in this issue and trying to help PFACs. And Beryl has had several sessions on Open Notes at their national meetings. Rosie, any comments about that?
My comment is that I think that I keep saying patients have volunteers, or hospitals have volunteers, patients and families volunteer at hospitals, and I think you can find champion volunteers who would be great at helping people develop the use of portals. So I think that, you know, I think that sometimes we don't use our volunteers in hospitals and clinics the best as we can, and we could be using them to help patients learn about their portal. I believe portals aren't being used as much as they could be because people don't understand them or don't see a reason to use them. If you give me a reason to use something, I will use it. And so that is, that is the whole reason why people don't use it, is because they don't see a value to it. And so if you could show people, if a patient to patient could show people, peer to peer, could show people why it is important for them to use it, they would use it.
Well, this is John. It's 10 o'clock Pacific. We've reached the end of the time we asked folks to dedicate to this, and so I think we should wrap up. Let me just say that I thought this was one of the best webinars I've ever been part of. And to Emory and Rosie, thank you so much. To everybody who asked questions, thank you so much. We got to a lot of them, but not all. And please send them along, or I think we might be able to figure out your email, and we can have the Emory folks or Rosie respond to your question, perhaps via email. So Amanda, unless you or Liz have anything else to say,
yes.
I think we should call this a wrap.
Yes, I will just say we have copied the questions that we didn't get to. We will get answers to them, and we'll include that when we send out the follow-up with the recordings. So thank you so much to everyone for the awesome questions.
All right, thank you.
Thanks, everyone.